Alright guys, it's Jake here again, ready for round 3 of Gross 2 Pass with your Exam 1 material. Today the goal is to get through pages 30 to 49, that way you will have all pass notes leading up to your first exam. And hopefully within the next couple of days our professors will get it all straightened out and send out our updated schedules, as we have been pushed back to May 1st as our return date to campus. At least that's what it is right now. So let's get going. Right now we are on page 31, and this is one of our more common matching sections here. Just going over some of the things within your nasal cavity. First, we're starting off with our sphenoethmoidal recess. It's a small space located above and behind that superior nasal concha. It receives the opening of the sphenoid sinus. Next, we have our superior meatus. It is below the superior nasal concha, and it receives the opening of your posterior ethmoidal cells. Superior meatus below the superior nasal concha, and again, superior meatus is associated with the posterior ethmoidal cells. Next, we have middle meatus, space below middle nasal concha, straightforward there. Receives openings of the frontal sinus, maxillary sinus, middle ethmoidal cells, and anterior ethmoidal cells. Next, we have our ethmoidal bulla. That's a round projection that goes into the middle meatus, and middle ethmoidal cells only open into that structure. Next, we have one of our more commonly seen things on this first exam, which is your hiatus semilunaris, otherwise known as your semilunar hiatus. We've seen it as a fill-in before. It's a curved slit lying below the ethmoidal bulla within that middle meatus. The frontonasal duct, anterior ethmoidal cells, and maxillary sinus open into the hiatus semilunaris. Next, we have our inferior meatus. The inferior meatus is the space below the inferior nasal concha. Receives the opening of the nasolacrimal duct. So that inferior meatus is going to be associated with where we will drain our excess tears. Lastly, nasolacrimal duct connects the lacrimal sac of the orbit to the nasal cavity. Again, this section here is going to be one of our more common matching sections. Nasal vestibule area just inside each nostril, so literally just right inside the nostril. That's where you have your hair, sebaceous glands, and sweat glands. Now, as far as the nasal cavity goes, we have two things to differentiate here. We have our respiratory region and our olfactory region. These guys, seen as test questions, know the difference here. Respiratory region is just the lower 2/3 of the nasal cavity, lower 2/3. It is also the largest part of the nasal cavity. Next, we have that olfactory region. That's going to be the upper 1/3 of the nasal septum. So olfactory is upper 1/3, respiratory region is the lower 2/3. We have a little fill-in up here, anosmia, and this should be a little callback from CNS, I believe, is just losing your sense of smell. So if you're dealing with a little anosmia, you cannot smell very well. When I was talking about my nose surgery last time for my deviated septum, I actually experienced this just for a little bit. After those first couple weeks, it takes a little bit of time for you to get your sense of smell back. Innervation, so we have that special sensory innervation from our olfactory nerve. That's how we smell. General sensation is coming from maxillary ophthalmic divisions of trigeminal nerve or cranial nerve 5, and it has both sympathetic and parasympathetic information from that pterygopalatine ganglion. Now, blood supply, which this is generally going to be more tested over than the innervation would be. So the main blood supply to the nose or nasal cavity is your sphenopalatine branch of the maxillary artery. This guy we've seen as a common fill-in. It is the most important branch, the other branch being anterior ethmoidal branch of the ophthalmic artery. We are talking about epistasis next, so that's just the fancy word for having a nosebleed. Very common for your nasal cavity, just nose in general, due to the rich blood supply. And we have two forms, mild and severe. Mild is just going to be caused from mycotrauma or low humidity. Severe form is going to be the one that involves kind of almost spurting arterial blood, and that is the result from a rupture of the sphenopalatine artery. So that is why the sphenopalatine is the most important, because if it is ruptured or compromised at all, you could have a severe nosebleed or severe epistasis. So as far as blood supply to the nose, the one you want to remember, sphenopalatine. A little fun fact he put up here was people lose olfactory receptors at 1% each year after the age of 50. And then cocaine abuse can accelerate that. I would venture to assume anything that you breathe in through your nose that you shouldn't be breathing in your nose could totally affect the way that you smell. So, just a quick little fact, people lose olfactory receptors 1% each year after the age of 50. So as you age, your special sense of smell tends to decline. Next, we're on to paranasal sinuses. Again, possible matching section. All nasal sinuses open into the nasal cavity. Potential true or false right there. All of them do. All or nothing, all. All of the sinuses open into the nasal cavity. They facilitate drainage. Formation of the paranasal sinuses is related to two factors. One, Wolff's Law, which I know you guys talked about in Phys 1. And then two, it's just to reduce the weight of the skull. So keep those two in mind. We've seen those guys pop up before. But the formation of our sinuses are due to Wolff's Law, and then straight up just to reduce the weight of the skull. Now we're talking about the sinuses here. We have our frontal sinus, lies in the frontal bone. This one opens into the hiatus semilunaris of the middle meatus via that frontal nasal duct. Maxillary sinus, this one is going to be the one most frequently prone to infection because it is poorly drained due to drainage openings being in a superior position, so which are high up on the medial side of the sinus. So because those drainage openings are superior to where the sinus actually is, it's very hard to drain, and it is the only paranasal sinus which may be present at birth. Only paranasal sinus that is present at birth. Possible test question there. Sphenoidal sinus opens to within the body of the sphenoid bone and opens into this sphenoethmoidal recess. Ethmoidal sinus. So this one is consisting of those several groups of ethmoidal cells. This one tends to be more of a test question we've seen. Essentially, you just have to be able to understand that your posterior ethmoidal cells open into your superior meatus, your middle ethmoidal cells open into the ethmoidal bulla within the middle meatus, and then your anterior ethmoidal cells open into the hiatus semilunaris, also within the middle meatus. Generally, one of these will be asked as a test question. We've seen it pretty straight up in the past, just as a multiple choice. The posterior ethmoidal cells open into blank, and you have to pick between superior meatus, middle meatus, ethmoidal bulla, that type of thing. So, posterior ethmoidal cells, superior meatus, middle ethmoidal cells associate with the ethmoidal bulla, also within the middle meatus, and then the anterior ethmoidal cells, hiatus semilunaris, middle meatus. Pretty straightforward question there. Another section we usually see test questions come from are our clinical significance section here of our nasal cavity. First, we're talking about the nasopharynx. Associate the nasopharynx with the most common place for infection to spread. It is linked to having a sore throat, otherwise known as acute pharyngitis. Usually, this section deals with, what part of anatomy are we talking about, and then what kind of pathology, if you will, is associated with it. So nasopharynx, we're associating that with acute pharyngitis or sore throat. Middle ear, we're thinking of ear infection or otitis media. Paranasal sinuses, we're talking about sinusitis, otherwise known as a sinus infection. We're talking about our lacrimal apparatus and conjunctiva. That's conjunctivitis, otherwise known as pink eye. Anterior cranial fossa within that cribriform plate. We're worried about meningitis or brain abscesses. Lastly, our mastoid air cells within the middle ear, mastoiditis. So again, think about the anatomy and the pathology associated with it. Special shout out to number 5 here, our anterior cranial fossa with the cribriform plate, because that brain abscess is going to be linked to this brain-eating amoeba, Naegleria fowleri. Know that word. Naegleria fowleri. It's hard to say sometimes for me personally. But again, brain-eating amoeba. It's from pond water. It will enter your nose and then it'll hitch onto your first cranial nerve and then travel to your brain. So that first cranial nerve will travel through the cribriform plate. And that's why these two are linked here. Next, we're talking about the oral cavity. These boundaries tend not to be hit very hard, so I'm not going to touch on that except for our posterior boundary. That is our oropharyngeal isthmus, which is demarcated by the palatoglossal arches. So essentially just the opening between the palatoglossal arches. This one tends to show up more than the others. So focus on that one when you're going through these. Oral cavity is divided into 2 parts. We have an oral vestibule and oral cavity proper. The vestibule lies between the lips and gums, or cheek and gums. In other words, it's the portion of the oral cavity that's external to the tooth rows. So we have a couple glands here. We have our labial glands, which are small salivary glands, and then a parotid duct, which is the duct associated with our parotid gland, which is our largest salivary gland. Next, we have our oral cavity proper, and that's just the rest of our oral cavity that is lying internal to the tooth rows. Lips and cheek. We'll talk about the philtrum here. Median groove seen externally, which extends from the nose to the vermilion border of the upper lip. That's the portion everyone has, literally from the inferior aspect of your nose to the superior aspect of your lip. And it tends to be what is, surgically corrected, if you will, when someone has, oh man, I'm blanking on it. I'm blanking on the terminology here. A cleft palate. Man, that one took me a while. Cleft palate. People typically have a scar where their philtrum would be if they've had a cleft palate corrected. Just something to hopefully help you connect the dots. Clearly it didn't stick in my brain very well, but maybe it will with you guys. Internally, each lip is connected to the corresponding gum via median fold. You have a frenulum of your upper lip and then of your lower lip. Now we get into the palate. Okay. So the palate is what forms the roof of our mouth and the floor of our nasal cavity. It does both. We have a hard palate. We have a soft palate. It's important to note that the hard palate forms the anterior two-thirds of the palate. The soft palate forms the posterior one-third. Know that for sure. Now we're getting a little specific with the hard palate here. It consists of the palatine process of the maxilla. That's going to be anteriorly. That's the most important thing there, palatine process anteriorly. And the horizontal plate, the palatine bone, and that is posteriorly. We have a couple foramina, incisive, greater palatine, lesser palatine. Incisive tends to be the one that is tested over more frequently. The mucoperiosteum presents a palatine raphe, which is seen here, just that line that goes down the top of that hard palate. It ends anteriorly at the incisive papilla, and that incisive papilla literally is there just to cover the incisive foramen. So it's a little small factoid, but it does tend to pop up. The incisive foramen, it transmits the nasopalatine nerves. Those guys are associated with cranial nerve 5. And the incisive papilla is what covers the incisive foramen. Again, very straight up, but we've seen it as a test question. We get to our transverse folds. So these guys are what aid in gripping of the food against the tongue during mastication. If you have a dog, you can look at your dog's hard palate, and they have pretty intense transverse palatine folds. Next, we have the soft palate. It's elevated during swallowing to close the opening between the nasopharynx above and the oropharynx below. Nasopharynx above, oropharynx below. It's continuous with two lateral arches, your palatoglossal arch, which has a palatoglossal fold superficially, and then the muscle, which is deep. And then second, we have our palatopharyngeal arch, which is again made of palatopharyngeal fold superficially, and then its associated muscle, which is deep. So main thing here, associate the soft palate with these two arches, palatoglossal arch and palatopharyngeal. Uvula, we all pretty much know what that guy is. That's the median projection of the soft palate, the little dangly thing that is chilling in the back of your throat. Next, we are talking about the tonsillar fossa. This guy tends to be a test question. It lies between the palatoglossal and palatopharyngeal arches. So we're thinking of that soft palate region. And on each side, it contains a palatine tonsil. Your palatine tonsils are the ones we want to associate with tonsillitis. The reason I point that out is because we do have a few other tonsils within our body, and sometimes a question will try to trick you up, and he'll ask just which of these tonsils is associated with tonsillitis. Know that the palatine tonsils, those ones are the ones right in the back of your throat near the soft palate. Now we're in the muscles with soft palate. Again, every time we get to a muscle section, we're thinking about our innervation and then our function. And anytime you get to a muscle section, think about how it could potentially also be a matching section. So we have our musculus uvulae. That's going to be made of two halves. Its innervation is the vagus nerve, which is cranial nerve 10, and then it elevates the uvula. Next, we have our levator villi palatini. Exact same innervation, which I have written here, as the musculus uvulae, except instead of elevating the uvula like the musculus uvulae does, this guy elevates our soft palate, especially when swallowing. Levator villi palatini, elevating soft palate when swallowing. Tensor villi palatini is innervated by our mandibular branch of the trigeminal nerve, cranial nerve 5. It tenses the soft palate, and it opens our pharyngotympanic tube, equalizing pressure. So that's important to note. If you've ever had your ears adjusted, that's kind of the theory behind that. If your ear is tugged on real quick with that short force, it's theorized that we're actually kind of manipulating that tensor villi palatini and opening that pharyngotympanic tube. These ones I'll point out are insertion. So origin insertion for tensor villi palatini. Origin is coming from the scaphoid fossa of the medial pterygoid plate, specifically that pharyngotympanic tube. Insertion is going to be the tendon winds around the pterygoid hamulus. So these are ones where we've seen a little bit of origin insertion pop up. Mainly, all you got to know, tensor villi palatini is associated with your pharyngotympanic tube. We saw this as a test question in our exam, but this whole muscle section can definitely be tested over for you guys. Again, muscles, focus on nerve and function. So, innervation and blood supply, not super big. We will talk about this here though, diagnosis of nerve damage. So damage to the left vagus nerve will cause the uvula to deviate to the right due to paralysis of the musculus uvulae on the left. So all you got to do is understand if one side of the vagus nerve is damaged, the uvula will deviate to the opposite side. So for instance, our left vagus nerve is damaged, which will create a deviation of the uvula to the right. So it's just opposites. Left vagus, uvula, pretend that's your uvula hanging off your soft palate, is going to deviate to the right. Super common test question. You'll get it a couple times. I know we talked about it again in NMS last try. So make sure you understand that one. Super simple concept and almost a guaranteed test question for you guys. Next, we're getting to the tongue. Functions tend not to be tested over too much, but they're very straightforward. Taste, mastication, swallowing, speech, all things we do every single day. So typically we won't see it on the exam, but just something to think about as we get into this section here. Parts of the tongue. This usually more of a lab practical type of question, so we'll skip through that for now. Talking about the dorsum of the tongue. It's the sulcus terminalis, V-shaped groove which divides the tongue into its oral and oropharyngeal parts. Again, you got to know oral part is the anterior 2/3, oropharyngeal part posterior 1/3. It's a common theme throughout the notes. A lot of stuff is split into anterior 2/3 and posterior 1/3. Make sure whenever you see that, you're thinking of it as a test question because these pop up quite a bit. Next, we have our foramen cecum, which was a test question for us. That's the foramen located at the apex of the V on the sulcus terminalis. So that's kind of that, if this is your tongue, that's the anterior part, this is your posterior part. That's sulcus terminalis right in the back. So right at the apex, where this red dot is, that's where that foramen cecum is going to be located. Main thing about this guy, it is the remnant of the embryonic thyroglossal duct. It is where you will see thyroglossal duct cysts. So for exam purposes, no, the foramen cecum is the remnant of the embryonic thyroglossal duct. Next, we're talking about the oral part of the dorsum. Oral, that's the anterior 2/3. We have a median groove, which is a shallow groove visible on the surface of the tongue, just running down the midline. Next, we get into our papillae. So one of these guys will pop up on your exam for sure. You got to know the difference between your papillae. So you have 4 different kinds. One of them is an easy odd man out, and that is your filiform papillae, because they do not have taste buds. The only papillae that don't have taste buds are the filiform. See, that test question is written right there for you. Next, we have our fungiform papillae. These guys are the mushroom shaped. They tend to be larger. They contain taste buds. Valate papillae. They're the largest. They're arranged in V shape near that sulcus terminalis, and it contains your taste buds. And next, we have our foliate. These are grooves and ridges along the margin of the tongue, so just the outer border. They're very poorly developed, but they do also contain taste buds. Next, we have the oropharyngeal part, otherwise known as the posterior 1/3 of the oral cavity. This is where we have our lingual tonsils, not to be confused with the palatine. Our lingual tonsils are a massive lymphoid tissue found on the oropharyngeal surface of the tongue. They are not prone to infection. See, this is where he tries to trick you guys up. Not prone to infection because we always wash them with saliva. That being said, our palatine tonsils near our soft palate are prone to infection. These guys lead to tonsillitis, like we mentioned before. But make sure you make that distinction whenever you see anything talking about a tonsil. Remember, palatine are the ones that get infected, lead to tonsillitis. Lingual, not prone to infection. They're literally just that little extra massive lymphoid tissue on the tongue. Next, we'll talk about the vallecula. We've seen it as a fill-in the past, know how to spell it. It is the space on either side of the median glossoepiglottic fold. Super specific little piece of anatomy, but we've seen it on the exam. Next, we have the inferior surface of the tongue, that bottom side. So, on the inferior surface, our tongue is connected to the floor of our mouth via the frenulum. And then a little pathology associated with the frenulum is called ankyloglasia. And this is one where I hate this one because I missed it on the exam. It was a fill-in. It was on the tip of my tongue, but I could not remember it while taking the exam. So still a little salty about it. But basically, ankyloglasia is tongue tie. So in some infants, the frenulum can be short, superior to inferior, so know that, short superior to inferior, and long anterior to posterior, which basically straps the tongue to the floor of the mouth. It can impede speech and other things that babies are trying to do within their first couple years of life. It can grow and kind of fix itself, but sometimes I actually think some chiropractors can treat ankyloglasia. I am not sure about that. Maybe ask Dr. Duray, but it's something that a lot of newborns will deal with. And again, I had a long-winded explanation, but essentially it is tongue tie. Now we're talking about the extrinsic muscles of the tongue. Our genioglossus, hyoglossus, styloglossus. These first three are all innervated by the hypoglossal nerve. And then our palatoglossus is the vagus. So that guy is our odd man out. Test question written right there for you guys. We'll go and break down each one of these guys. Again, whenever we see muscles, we're thinking innervation and function. Nerve for the palatoglossus, again, it's what makes it different than all the other guys, is it's innervated by the vagus nerve. It functions to elevate the back of the tongue. All extrinsic muscles of the tongue, except for the palatoglossus, are innervated by the hypoglossal nerve. There, he says it again. Up here, he has them even listed in order, making that palatoglossus the fourth guy, odd man out. And then he says it again down here. It's a super common test question. Clinical importance of the genioglossus. It's not super tested on, but the genioglossus will pull the tongue forward. So, in comparison to the palatoglossus, it'll elevate the back of the tongue. Genioglossus pulls it forward. It essentially prevents it from falling backwards and blocking your airway, and it can prevent you from potential suffocation. That's most important, if you're having surgery and you're under general anesthesia, or if you know someone that has epilepsy. So just something to keep in mind. Sensory innervation. This is one innervation we definitely want to talk about. The anterior 2/3 and the posterior 1/3 of the tongue have different innervation. Anterior 2/3 is coming from the lingual nerve, which is a branch of our trigeminal nerve, cranial nerve 5. This is where you're going to get taste on the anterior 2/3 of the tongue, and that is through your facial nerve and your chorda tympani. So general sensation is just the lingual nerve, which is associated with the trigeminal nerve, and then taste, also associated with the anterior 2/3 of the tongue, is your facial nerve. For the posterior 1/3, both general sensation and taste are coming from cranial nerve 9, or the glossopharyngeal nerve. So be able to differentiate your anterior 2/3 and posterior 1/3. Know that anterior 2/3 has two different innervations for the general sensation and taste, while the posterior 1/3 shares the glossopharyngeal nerve for both. I'll also point this guy out here. I'm not sure if he'll have you add this or not, but the glossopharyngeal nerve will also innervate that valley papillae, and it's the initiation part of your gag reflex. Blood supply and lymph nodes, not super important. Next, we'll get into teeth. So their function generally pretty obvious. They're there to help break down food while we chew in order to increase surface area and facilitate enzymatic activity and absorption. Simply put, just to help us break down food. We'll point out some of these structures. Enamel is going to be the hardest substance in the human body. Harder than bone, enamel. Next, we have pulp. I'll point that out because this is where we can see our blood vessels, nerves, lymphatics, entering into our teeth there. And then cementum, it's bone-like substance that covers the root. And I believe he'll have you add this. It is the only part of the tooth that is part of the periodontium, which is the attachment mechanism of our teeth. So, if I were you, I would focus on 1 and 4. Enamel being the hardest substance in the body, and cementum being the only part associated with the periodontium. Next, we have the parts of the teeth. Again, typically more lab type of stuff. And then we get into the different kinds. So we have our incisors, single rooted, used for cutting, 2 per side. Canines, again single rooted for puncturing and tearing, 1 per side. Premolars, they can be single or double rooted. They're used for grinding, 2 per side. And then our molars, these guys are the only ones that are multiple rooted. They're very broad, also used for grinding, 3 per side. And then that third molar, hopefully none of you guys have had the great fortune of having your wisdom teeth out. I have. It is a miserable process in my opinion. But they can become impacted and they can create pain via dental crowding in your mouth. So that is that third molar. That tends to get taken out in most people. Surfaces of the teeth. These guys are worth knowing. I'll run through them quick. Typically, we see this as a lab question, but it has shown up on your written exam as well. The labial surface, we're only talking about incisors and canines here. That is the side of the teeth that is facing your lips, the inside of your lips. For premolars, the labial surface is facing the cheek. So basically just the outer surface of your teeth that's facing the inner surface of your mouth, if you can visualize that. Lingual surface of each tooth is the side that's facing your tongue. Mesial surface is facing anteriorly toward the midline. That's kind of the surface where you would floss. Distal surface is the surface facing posterior away from midline. Occlusal, that's where your teeth articulate with one another, that's where you chew. Again, usually they'll point at these when you're taking your lab practical and ask you which surface they're pointing to, but we have seen it on the exam, which is why I wanted to point it out. Next, we have our two sets of teeth. You got to know deciduous means baby teeth, so you lose those guys, and then permanent means your adult teeth. Permanent teeth are larger, wider, have thicker enamel. That's that hard substance that protects your teeth. Each jaw can be separated into a left and right quadrant. For deciduous teeth, you have a total of 20 teeth. This is one of those times when you're going to want to know numbers. Permanent teeth, you have 32. So deciduous, 2 incisors, 1 canine, 2 premolars in each quadrant. So that's 5 teeth. You have 4 quadrants. That's where you get 20. Permanent teeth, 2 incisors, 1 canine, 2 premolars, 3 molars. That's 8 teeth. Times 4 gets you your 32. So again, these are some numbers you're going to want to know. Permanent teeth, you have 32 of them generally. Some people can have more. Deciduous teeth, you got 20. Next, we have our innervation. So it's the reason I point this one out is because the teeth, your upper row of teeth, maxillary row, are innervated by the superior alveolar branch of the trigeminal nerve, while your mandibular teeth, your lower jaw, are innervated by the inferior branch. So they are technically coming from the same nerve, but they are different branches. Know that they are different branches. Maxillary teeth above are superior alveolar, mandibular teeth below are inferior. Now we're into the pharynx. It's where you have your pathway for food and air. It's considered both digestive and respiratory. Digestive and respiratory. The pharynx will lie posterior to the nasal cavity, oral cavity, and larynx. It consists of 3 parts. So your pharynx has a nasopharynx, oropharynx, laryngopharynx. They're all straightforward. Nasopharynx is posterior to the nasal cavity, oro, posterior to the oral cavity, and then laryngo, posterior to the larynx. We'll dig into each one of these guys. It's the nasopharynx. You might want to know this level. That's going to be more of your C1 level. It communicates with the nasal cavity through conae, and with the oropharynx through pharyngeal isthmus. So that nasal cavity is through the conae that we talked about previously, and with the oropharynx, it's that pharyngeal isthmus. So boundaries, these guys are worth noting. Every once in a while you'll see a boundary question pulled from here. Superior boundary of the nasopharynx is the roof of the pharynx. Inferior, soft palate. Anterior is going to be the posterior border of the inferior nasal concha. Posterior border, posterior wall of the pharynx. And next we have another set of tonsils, your pharyngeal tonsils, otherwise known as your adenoids. They're embedded in the posterior wall of your nasopharynx. They can become enlarged, causing difficulty breathing through the nose. So some people might think they have a deviated septum. They go in and get it checked. They have a CAT scan done. There is no deviation, but they still might have trouble breathing due to these adenoids. And they are the second most commonly removed tonsil, behind number 1, which I hope by now you can tell me that the number 1 most commonly removed tonsil are your palatine. Those guys again, tonsillitis. Next we have our pharyngotympanic tube, or auditory tube, is in the lateral wall of the nasopharynx, and it is limited above by a cartilaginous structure known as the torus tubarius. Know that word. Torus tubarius is what limits our pharyngotympanic tube. Possible fill-in. That tube also will connect the nasopharynx with the middle ear. It's what is equalizing pressure between the nasopharynx and tympanic cavity. And then again, infection can spread from the nasopharynx to the middle ear because of that connection and lead to otitis media. So it's kind of interesting how your pharynx, kind of the more posterior aspect of your nose, is connected to your middle ear because of our pharyngotympanic tube, and we can have kind of an ear infection almost come from our nose via that nasopharynx area. Tubal tonsils, again, another set of tonsils. I'll say it again, make sure you know your tonsils. You do not want to miss a question about tonsils because you're all jumbled about which ones are which. Pharyngeal tonsils, those are your adenoids. They're most commonly removed, or secondly most commonly removed. And again, palatine are your first. Those ones are associated with tonsillitis. Tubal tonsils are just straight up small tonsils. They lie immediately behind the pharyngotympanic tube. So tubal, think pharyngotympanic tube. Don't think about infection. Next, we're in the oropharynx. We'll go through the boundaries with these guys again. This is one where he could try to trick you guys up and mix and match boundaries from the nasopharynx, oropharynx, and our last pharynx, which I'm blanking on, laryngopharynx, excuse me. So our superior border is our soft palate, inferior border, superior border of epiglottis, anterior palatoglossal fold, and posterior is going to be that posterior wall of the pharynx. Oropharynx lies from C2 to C3. Remember, naso is C1. Make sure you're knowing these levels. These guys tend to pop up on exams. It communicates with the oral cavity through the oropharyngeal isthmus. Palatine tonsils are found in the oropharynx. Again, these guys are linked to infection, tonsillitis. Please don't miss that question. They are located between two folds, our palatoglossal fold, palatopharyngeal fold, which we talked about a little bit earlier. Space between these folds, your palatoglossal and your palatopharyngeal fold, is called your tonsillar fossa. Palatine tonsils are most frequently removed during childhood, and that is because of tonsillitis. You have your tonsillar ring. It's a circular arrangement of tonsils around the oropharynx formed by all of these guys are lingual, palatine, tubal, and pharyngeal tonsils, so they all combine to form this ring, and the reason they're there is to act as a defense against infection, but we know palatine is usually the culprit for tonsillitis. And then every once in a while we worry about our pharyngeal, which is our adenoids, and they can get enlarged, inflamed, and block our breathing. Again, hopefully the last time I have to say it, know your tonsils. Now we're on to the laryngopharynx, so that's C3 to C6. Again, oro was C2, C3, and naso was C1. Boundaries: superior border of epiglottis, inferior lower border of the cricoid cartilage, anterior posterior surface of larynx, posterior wall of larynx. Again, he can kind of try to trick you guys up between these different superior, inferior, and anterior and posterior borders of the laryngopharynx compared to our oro and nasopharynx. It's not a super common test question, but we have seen it in the past, so that's why I'm pointing it out. Next, piriform fossa. So this one's an interesting one to ask question. It's a recess in the anterior wall of the laryngopharynx, piriform fossa, laryngopharynx. It's located on either side of the laryngeal inlet, and foreign objects, like fish bones specifically, can become lodged there. Know that term, fish bones. I don't know why that is the example, but it is. And essentially, this piriform fossa can act as a place where your food and other foreign objects like fish bones, I don't know who's trying to eat a bunch of fish bones, but They can become lodged there, and when they're lodged there, like anything else, it's going to just kind of slowly decay in the spot it's lodged, which will lead to halitosis. Halitosis, try to know how to spell it. That's just really, really bad breath. We've seen it as a fill-in, but you got to know halitosis associated with that piriform fossa. Fun little fact. So muscles of the pharynx, we have two layers, an external circular and a longitudinal layer. We'll go through our external layer of muscles first. Again, we're thinking nerve and function when we see muscles. All of the muscles of our external layer have vagus innervation. It's worth noting that our inferior constrictor muscle also gets a little bit from that external laryngeal nerve, which makes it a little unique. They all do the exact same function. They all contract the pharynx during swallowing. So they're all working together to contract the pharynx while you swallow. Again, all vagus nerve innervation, except we get a little bit from the external laryngeal with our inferior constrictor. We then also have our palatopharyngeal sphincter. It's a band of muscle formed by the superior constrictor, and it helps seal that pharyngeal isthmus while you swallow. So it just acts as a seal. Now we're on to our longitudinal layer of muscles. These guys have an odd man out with your stylopharyngeus, as it's innervated by the glossopharyngeal nerve. The other two, palatopharyngeus and salpingopharyngeus, are both innervated with the vagus nerve. So, if we're looking at our muscles of the pharynx as a whole, looking at both layers, the total odd man out is that stylopharyngeus as far as innervation goes. It is the only muscle of our pharynx that is innervated by the glossopharyngeal nerve, otherwise known as cranial nerve 9. Everybody else has vagus innervation. Again, a little special consideration with our inferior constrictor because it does get something from the external laryngeal. Now, our stylopharyngeus elevates the pharynx. Our palatopharyngeus will also elevate the pharynx but narrows the oropharynx. Salpingopharyngeus muscle will also elevate the pharynx, so that's what they all have in common. They all elevate the pharynx. That's the longitudinal layer. And it will also open the pharyngotympanic tube. So, our salpingopharyngeus muscle works with our tensor veli palatini to open that pharyngotympanic tube. So, a little connection there. Next, we have nerves of the pharynx. So, we have our pharyngeal plexus. It's a network of nerves which lies right on top of the middle constrictor. It's formed by our pharyngeal branch of the vagus. That is motor to all the muscles of the pharynx except for the stylopharyngeus. So he literally has that written right here straight up in this section and throughout this muscle section. So it's a super common test question. The pharyngeal branch of vagus nerve is motor to all muscles of the pharynx except for your stylopharyngeus. Stylopharyngeus is our odd man out. So our pharyngeal branch of the glossopharyngeal nerve is just sensory. And then we get some sympathetic fibers from our superior cervical ganglion. Arteries not super tested. Now we're into our fascial spaces here. We have our bucopharyngeal fascia. It surrounds the pharynx external to the muscles. So it's kind of encapsulating those muscles. It's continuous with the pretracheal fascia below. We have our retropharyngeal space, which is a potential space between our bucopharyngeal fascia and our prevertebral fascia. It extends down into the thorax and permits free movement of the pharynx and esophagus while swallowing. So retropharyngeal space gives you that free movement of the pharynx and esophagus during swallowing. Clinical significance of our retropharyngeal space: we can get hemorrhage from our cervical trauma, or an abscess from our pharyngeal infection. It can cause the posterior wall of the pharynx to balloon forward, and it can cause you to suffocate. Later on, you will get into Diagnostic Imaging 1, which is also the other class I tutor. You guys are going to be so blessed to have me twice. And when you get into Imaging 1, you actually learn the measurement that you're looking at. When you take a film, if it's greater than X amount of centimeters, that's when you're worried about some possible edema or abscesses within that retropharyngeal space, which can lead to suffocation. So it's actually something that you can see and measure via X-ray, which is kind of cool. I believe it's greater than 7 millimeters, for those who are wondering. Next, I think lastly, we did it, guys. We're at the end. Swallowing, otherwise known as deglutition. This is one where you don't need to completely memorize, but you want to understand kind of this sequence. So the tongue is where we're starting here. We'll move the bolus of food into your oropharyngeal isthmus. Your palatoglossus and palatopharyngeus muscles are squeezing the bolus back into the oropharynx. At the same time, your levator veli palatini and tensor veli palatini elevate the soft palate and close off the pharyngeal isthmus. Next, we have our stylopharyngeus, palatopharyngeus, salpingopharyngeus elevate the walls of the pharynx. So that's where we're elevating the pharynx. Our suprahyoid muscles elevate the hyoid bone and larynx under the bulge of the tongue, and it flexes the epiglottis back over the laryngeal inlet. Our superior, middle, and inferior constrictor muscles are then contracting and squeezing to move the food through the oropharynx, laryngopharynx, and into our esophagus. Then the rest of the way is peristalsis, which is just propulsion of that bolus downward into the stomach. So again, this is kind of a large section. There's a lot of muscles and stuff going on. Just understand kind of a general order. Your tongue starting first, moving that bolus towards your oropharynx. Then your palatoglossus and palatopharyngeus get involved, squeezing the bolus back even further. Then we're elevating the soft palate with our levator, or essentially our palatini muscles, both of those guys. They're elevating the soft palate. Then we get into our pharyngeus muscles, which are elevating the pharynx. Then our suprahyoids, which are flexing the epiglottis back. And then our constrictor muscles, lastly, which are contracting and squeezing the food past the oropharynx, past the laryngopharynx, and into your esophagus, where it's then taken to your stomach. Again, know the general order. It's not super highly testable section, but important to know. And then possible fill-in. This is what we'll end on. Dysphagia is also known as difficulty in swallowing. All right, guys, this is usually where page 49. This is usually where the end for exam 1 material is. I'll send this out to you guys, and I'll try to communicate with a few of you to just confirm that this is in fact where you're ending for your first exam. I hope you guys are all doing well out there. Try not to stress too much. We're all in the same boat. None of us really know what's going on as far as when or how we're going to be tested, but I can guarantee you I'll be there for you guys along the way. Whenever we figure out when your first exam is, I will be able to send out a Kahoot review for you guys and just answer any possible review questions you might have. So, as always, feel free. That's supposed to be a dot. I always do a dash. jacob.parks@palmer.edu. Shoot me an email. Hit me up on our Facebook page if you have any questions, any concerns at all. I'm always happy to help. All right, guys, that's it. Have a good rest of your week. Thanks.